Well, hello. Welcome everyone to the July 9th session of the Virtual Learning Collaborative, HCV RNA Point of Care Testing, Initial Implementation Successes and Challenges, made possible in partnership with the CDC Division of Viral Hepatitis. My name is Zakia Grubbs. I'm a senior manager here on the hepatitis team at NASTAD. The format for today's session is as follows. We will begin with presentations from Liz Ohlsen from the Alaska Department of Health and Jennifer Price from the University of California, San Francisco Deliver Project in San Francisco, followed by a moderated discussion led by Katie Burk. So feel free to use the chat to introduce yourselves and your jurisdictions and your questions. So yeah, thank you all for joining us, and I'm going to turn it over to Liz to start us off. I can stop sharing.
Thanks, Zakia. Just sharing my screen here, and hopefully everyone can see this now. So I'm Liz Ohlsen. I'm a staff physician with the Alaska Division of Public Health on the hepatitis team, as well as a few other teams. And we'll just quickly overview our beginning point of care hepatitis C RNA testing going on in the state. So quick overview, hepatitis C in Alaska is fairly prevalent, especially in South Central and Southeast Alaska, with rates particularly high among folks under 40, and our viral clearance is below national average. We have some sort of steady state efforts going on. We have a strong opt-out testing partnership with the Department of Corrections, where they offer hepatitis C as well as HIV and STI testing on an opt-out basis to remands passing through their system. And then the DOC does do treatment for inmates who will be in their system for the duration of treatment plus SVR12, but that's a small proportion of people passing through corrections, compared with many people who are passing through for shorter time. Public health centers across the state also offer hepatitis C testing. And then we have tried to get the word out about hepatitis C rapid testing and treatment start through letters to clinicians and other communications. So as soon as the hepatitis C RNA rapid test, as soon as it was approved, we started trying to think through how to strategically expand this throughout the state, and had some unobligated funding from a CDC hepatitis grant that allowed us to facilitate a public health center-led outreach pilot with hepatitis C RNA rapid testing. And so we used unobligated funds to purchase two gene expert machines, cartridges, some controls and supplies, and then the public health center nursing time was contributed through their usual budget. So currently this pilot is running at 2 public health centers in Alaska. The first center is in a city of about 30,000 population, including an estimated 200 people experiencing homelessness. This site was chosen in part because there's a syringe service program that's geographically co-located with a homeless shelter and a mobile outreach clinic within about a city block. And the public health center specifically has a public health nursing champion who facilitated this pilot. She was a member of the state hepatitis working group and was also on the board of the homeless shelter. So this was sort of a very ideal situation for partnerships to support this effort. So initially the machine was located in the homeless shelter and then ended up moving to the syringe service program, just because of dynamics within the shelter. And then the mobile clinic, which is unaffiliated, there's not a formal affiliation with the public health center, but the mobile clinic that was operating in the area takes referrals for follow-up labs and for hepatitis treatment initiation, as well as public health nursing, helping with labs, case management, facilitating incentives, and then in some cases also facilitating treatment. So this is the longest running site in the pilot, with testing beginning in March 2025. They've been able to test 33 clients with 8 positives, which is almost a quarter of the folks tested, and then a high number of indeterminate tests, which we'll talk a little bit more about later. Of those 8, one's been lost follow-up through. I'm getting some of it. Okay, so 1 was lost follow-up through outreach and progress. 2 have been linked to care at a clinic in the community. 1 is in process of starting treatment through the public health center, and 1 has started hepatitis C treatment through the public health center. And then I'll just note that in the first 2 months of the pilot, there were many indeterminate results using the Cepheid machine. After switching to a new lot, those cartridge issues seem to have been resolved, and some of those patients have been able to be located for retesting. Moving on to our second center, which is a much more recent addition. This is a larger city with a larger estimated population of people experiencing homelessness. The Public Health Center has a new effort where they're really trying to increase outreach to homeless encampments and shelters, and with that, working towards improving their ability to start hepatitis C treatment in-house as well as refer. They're hoping to be able to start a syringe exchange program. They're currently referring for hepatitis C treatment and MOUD while providing hepatitis C and STI testing and STI treatment. But as I said, looking to expand services in the near future. And I should just mention that a lot of that is dependent on staffing and being able to hire people, which is always a challenge in Alaska. So in the center 2, the machine's located in the mobile outreach van, and they do the rapid RNA testing simultaneously with blood draws for hepatitis C and viral load and hepatitis B status and gonorrhea and chlamydia swabs, as well as rapid HIV and syphilis testing. And they're also able to offer incentives for testing and treatment. So in terms of outcomes, they were focusing many of their outreach efforts on a large encampment in early June, and were able to conduct 8 tests, of which 2 were positive, and again, having challenges with indeterminate results. So, and we'll come back to those as well, but the labs were drawn at the time of testing for hepatitis B status, for hep C viral load, and for other labs needed to start treatment. So, the FIB4 labs as well. The positive patients have not yet been able to be relocated to start treatment, and complicating matters, this large encampment where many people were living has since been evicted by the city. So that's really made many of the locating efforts much more challenging. So there's a couple of new opportunities in Alaska that we're hoping to expand our partnerships with. Our very close partners within the hepatitis program with the Tribal Health Consortium in Alaska are starting a similar model. We also have a large FQHC adopting hepatitis C RNA rapid testing, and we're hoping to support their efforts. And then other clinics are interested, so we're trying to talk about these efforts as much as possible to get clinics and other places to start thinking about point of care testing and rapid or same-day treatment starts as something they can integrate into their practices. So our main challenges you'll be very familiar with. The cost of treatment is, of course, a very large barrier. While Alaska Medicaid does not have barriers to treatment initiation for patients who have current Medicaid eligibility, many private insurances, of course, do, and of course, anyone who's not presently on insurance faces a very high barrier to cost, and we don't presently have a good way of being able to cover costs of treatment for patients without insurance. We're also working through helping primary care physicians in the state, understand that this is although it's a somewhat recent change, that all genotypes of hepatitis C can now be readily treated in primary care settings using labs that, speaking as a family physician myself, we're all comfortable ordering and interpreting, and that this really is something that the hepatitis C treatment for most patients has moved into well within the realm of primary care. I'm 5 years out of residency myself, and when I was in residency, we still had to refer some genotypes to specialists. So I think that we are really dealing with kind of a rapid culture shift in what can be done in primary care for hepatitis C here in Alaska, and I think that it does take a while to get that message out. So we're trying our best to get the simplified guidelines and sort of the standard of care being to treat most cases of hepatitis C in primary care to get that word out to clinicians. Access is, of course, a barrier. Our highest priority population are people who are currently injecting drugs, in part because it's the right thing to do for their health to treat them for hepatitis C when they have it, and also because they're at the highest risk of transmitting hepatitis C to others. And so people in that group frequently face barriers like transportation or getting their medicine stolen or other things. So we're working through kind of those logistical barriers, and then also acceptability of care among a group that faces, or groups that frequently face stigma, including in healthcare. In one of our largest sites, the encampment eviction was followed by new criminalization of camping in many public spaces, and so those relationships and trusting relationships in general have become more challenging for that health department with people experiencing homelessness. As well as the challenges with the hepatitis C RNA test themselves. Of course, engaging patients for similar reasons we just discussed is always challenging, and so incentives are helping a little bit with that. Obtaining samples has not been straightforward. So many of you may be used to using fingerstick blood test devices, and these tests just happen to require a much larger volume of blood than many other tests. So our clinics have had to switch to using much larger lancets to be successful. Warming hands is really key. Making sure that patients are hydrated is really key, and then a careful choice of sites where there aren't calluses on the fingers or something else, to make sure that you actually get an adequate sample. This isn't necessarily a quick sample acquisition. The fastest I've been able to get a sample myself is probably a minute or two, which is a long time when somebody's standing around outside in the rain, or otherwise has things that they're trying to do. And then getting the cartridges to work has also been challenging. We've had indeterminate results, some of which have been because some of which resolved when we switched to a different lot of cartridges for one clinic, and for the other clinic, some of the microtainers that came with the cartridges weren't working, and so they switched to another lot, and that problem resolved, and they stopped getting indeterminate results. But we've gone through more controls than we expected to, and the controls are bought from a separate company and are themselves somewhat expensive. And so we've just kind of had to have people do many more repetitions of control testing, and then had to repeat a lot more tests than we were expecting to. I'll skip to the fourth icon here, which is follow-up. Follow-up and locating people, especially who don't have a consistent address, is of course very challenging. Who get their phone stolen is very challenging, and that's just sort of one of the realities of trying to reach some of our higher risk groups. And then the third one here is hepatitis B status. And so we were working from 2021 AASLD guidelines, which were the ones we were aware of until about a week ago, which state that that hepatitis B status is recommended to be known before initiating treatment. And we just could not figure out how to do same-day treatment starts and follow those guidelines. We don't have a hepatologist with the hepatitis program. I'm a family physician, and so we don't really have the in-house expertise to write our own guidelines. So we were waiting on federal guidance or another helpful guideline to be able to move towards same-day treatment initiation on a patient with unknown hepatitis B status. And that's since been resolved with the new AASLD guidelines that I think have been posted for a while, but that we're now aware of, and those are on the front page of hcvguidelines.org. So what we're working on now is revisiting all of our protocols and helping people understand how to appropriately counsel people for a risk of hepatitis B reactivation if they do happen to have it and they start hepatitis C treatment. But we're hopeful that we're going to be able to go to an actual same-day treatment initiation model instead of the model that we've been using so far, which is to confirm viremia on the first visit, draw labs, and then call people back for a second or subsequent visits in order to actually start treatment. And so the next slide is our contact information. It's not me, it's a team. Please feel free to reach out to any of us, and I believe Zakia will be able to share these afterwards. Thanks very much. I'll hand it over to maybe Jennifer. Please go ahead and share your slides to kick my slide sharing.
Sorry, I was muted. Great, thanks, Liz. Can everybody hear me okay?
Yes.
Okay, great. So I want to thank you for inviting me to speak here. Following up on Dr. Ohlsen's presentation, I'm going to present some of our experience on the community side, integrating the Hep C RNA point of care testing on a mobile unit. My name is Jenny Price. I'm a hepatologist at UCSF. And here are my disclosures. I actually also am one of the co-chairs of the AASLD IDSA Hepatitis C guidance panel. So I'm happy to answer questions also related to the new test and treat algorithm if that comes up. But just to start, I wanted to just give a little bit of background of what we were doing before the point of care test became available. I run our viral hepatitis center, and we have a dedicated hepatitis C clinic that's, a brick and mortar clinic. But back in 2019, we launched a mobile unit to go out into the community and perform Hep C screening. And initially, the plan was to do linkage to care in the community, but that evolved very quickly to on-site hepatitis C treatment as well. So around mid-2019, we started piloting the testing and on-site treatment on the van. This was obviously not same day at the time. And so this is sort of our standard model now that has evolved since then, but this is what our clients can anticipate if they're getting screened on the van. So the first visit that we do, we traditionally have been using the rapid Hep C antibody test. And then if that's positive, then we have very good skilled phlebotomists on the van who can conduct venipuncture and then send that out for confirmatory RNA tests. Because we're mobile, we're not a fixed site, we they can't come back the next day necessarily, or, in 2 days. So we purposely have our schedule so that we're at the sort of same site, same day of the week, the same time. So Friday mornings at a certain place, Thursday mornings in another place, for example. So people would have to come back the following week, get their RNA results disclosed. And if their RNA was detectable, that's when we sort of switched from the screening model into sort of the treatment model. And that's when we'll ask people if they would like to get treated with us or get referred to somebody else. If they want to get treated with us, we'll collect all the insurance information that we need, all the sort of regular stuff that you would fill out when you're visiting the clinic. And then we would get the insurance authorizations for a clinic visit, which would happen the following week. And we conduct these through telehealth with either myself or one of the nurse practitioners or other physicians in the hepatitis C clinic. At that telehealth visit, we could also draw any pre-treatment labs that already have to be done. So by that point, we've already, we have the patient's MRM. We could look up their past medical records, including records at other facilities, and see if they've already had the hepatitis B serologies, for example, or if they need need testing. So we'll see people at that treatment start the first visit, first clinician visit, draw any labs that need to be done and come up with a treatment plan at that visit, knowing that the labs were still pending, and send the prescription to the pharmacy. And then the following week, the labs will have been back and the DAAs are brought to the patient on the van. And then we do another visit where we do a treatment start visit. So, lots of steps, but a sort of streamlined, I would say, course, and all fairly convenient because it's, one stop on this mobile van. But you can see how having a point of care RNA test would be very appealing to us because we could at least skip this first step entirely and just go straight to the RNA test performance and results disclosure. And with this, it also allows us to think about how we could maybe combine or condense these steps as well, and even do same day treatment starts. So we received some funding from our San Francisco Department of Public Health to pilot the Gene Expert device, similar to what we heard Dr. Ohlsen with their site. So we were one of the sites piloting this on our van, and there were a lot of things that we had to think about before we were able to actually start the demonstration project. And those are the different aspects that I included on the slide here. And I want to go through most of these. So, we had to think about getting the supplies, getting the device and the cartridges. I'm not going to actually talk about that anymore here. But obviously that's a major issue because it's expensive. And then the other elements were the regulatory, the training, figuring out our workflow. And then we also thought it was very important as we do this to have process evaluations so that we could, learn from what we were doing and hopefully use what we were doing to help inform other programs. So starting with the regulatory, now, this might be different depending on the jurisdiction, and a caveat, I'm a hepatologist. I'm not a lawyer. But the main components that we had to consider here was first, of course, the federal CLIA certification, which we had for the point of care antibody testing here in California. Facilities that perform CLIA waived tests also have to secure a California state laboratory registration or licensing. So that's also a requirement specific to California. We had to think about the result reporting. Again, in California, there are specific mandates. We have to report positive Hep C RNA results to the local health authorities within 1 working day of identification. And this is something that was new for us because although we were doing Hep C RNA testing before, they were sent out to the Quest lab. And so Quest was the one that was reporting to the health authorities. Also, there's an issue in terms of personnel training and scope of practice. So in California, people are considered to be authorized personnel to conduct point-of-care hepatitis C testing if they're trained healthcare professionals, and this is part of their scope of practice. And the trained healthcare professionals include what I've listed here, MDs, APPs, RNs, et cetera. It doesn't include phlebotomists, and that's primarily who is staffing on site on our van. So non-medical personnel also can conduct the point of care testing, but they have to complete appropriate training that's approved by the California Department of Public Health. So our team, for example, had completed this training before, but the training was for HIV and Hep C antibody testing, not Hep C RNA testing. And then, appropriate quality assurance practices have to be in place when doing these point of care tests. So on that latter note, in terms of the quality assurance practices, I included this screenshot because this is something that the California Department of Public Health can provide to community organizations for point of care Hep C antibody testing. And this is sort of the QA guidelines. And this is just extremely helpful for sort of smaller groups that are starting these community-based tests like we had. The RNA point of care test is newer, and so I'm not aware of any existing sort of guideline like this, but this is something that would be very, very helpful to develop so that people can reference something like this when they're setting up their own programs. And this is just some screenshots from the package insert for the Gene Expert Express system. Just I randomly took a few different screenshots, but you can see a lot of the information that you would include in that QA guideline is already in the package insert, but maybe needs to be adapted or something for individual programs. But there's a lot of information about how to use the device, obviously, and the quality controls, the use of when to do the controls, etc., actually in the package insert. In terms of staff training, the device was sort of the concept of the device is that you don't need very much training to perform it, and that you could do it in a CLIA wave setting, which is true, but there is a lot of training that does need to be considered before you're ready to actually use it, in the field. And so I just listed here some of the things that I think are really key components of training staff, and particularly when the audience is sort of non-medical personnel who are going to be performing the training, things that we would want to make sure that they have the background on before using the device. And those include, of course, background on hepatitis C, how to be conducting the test safely, the quality assurance issues that we talked about, how to collect the specimens. We heard from Dr. Ohlsen about the amount of blood that's required, for this, and it is pretty significant. So a lot of training on finger stick and how to get the sufficient amount of blood, and what to do to troubleshoot, with the warm compresses, etc. The test procedure itself, so how to operate the device, and then how to interpret the results, and then really importantly, how to disclose the results. And so the California Department of Public Health staff training really includes a lot of training on counseling for results disclosure. The trainings, of course, should also include compliance with local regulatory requirements, and then some practice runs, so hands-on training, and finally, proficiency testing. And then I think there's some other things that would be desirable in terms of staff trainings, and those might be co-designing them with the people who are going to be using the machines, and integrating their feedback into the formal training. Possibly having some flexibility in terms of the options for training, providing standard operating procedure documents may be helpful. And then I think really importantly, ongoing operator support to sort of troubleshoot the things like we heard, happened with the group in Alaska with some of the cartridges and those things. Like, I think we should expect that these things might come up, and that we're going to need to know what to do in terms of who to ask for support and how to support people. And then finally, I think after the training, I'm not sure that this should just be one training. I think we need to sort of review how people are doing several months into the projects and consider retraining. And I'm not sure what the frequency of retraining should be. So moving on from staff training, I just want to talk about our workflow, what we've sort of decided to start with on the van. Instead of doing the viral first testing in everybody, we wanted to sort of start slow and sort of get our feet wet and see how it goes. And so we came up with this flow where if somebody interested in testing had previously received a Hep C diagnosis, they get, then we ask if they are currently on DAAs, or if they aren't, if they stopped within 4 weeks. Most people will say no to this, but some people might come to the van and be on their DAAs. If that's not the case, then we'll go for the RNA testing first. Conversely, if someone comes in, they've never had a Hep C diagnosis, we ask about recent exposure. If they haven't had a Hep C diagnosis and haven't had a recent exposure, right now we're sort of triaging to our regular workflow, which is the antibody test. But if they have had a recent exposure, we triage to the RNA first. And then also right now, since we're still learning about the device, we're giving people the option of the point of care RNA versus the standard venipuncture blood draw. And this is what it looks like. In the field, we have tablets, and we just have a survey that comes up so that the operators can just ask questions quickly in the field. And if they say no, they've never been told that they had Hep C and they have not had recent exposure, then the person on the tablet will get this pop-up that says they're eligible for antibody testing, and conversely, if they're eligible for RNA testing, that will pop up. So I mentioned that we also, as we were launching this pilot, thought that it was important to include and incorporate evaluation throughout the pilot. And that we thought was important, to assess our progress, but also identify opportunities for quality improvement and document the lessons learned to inform similar programs and maybe prevent people from having to go through some of the issues that we might go through. That has started initially with a formative interview. A consulting group has interviewed staff and community partners, but this was before our launch, but as we were preparing to actually launch the device. And they identified a few key themes. First was that preparing to implement this new technology requires multiple steps. We heard a lot about about this, what I already said, and also what Dr. Ohlsen said. Here's just a quote: if a non-clinician is using a machine, they have to be trained to do the point of care test, but there's no formal training that exists yet. It's sort of a circular thing. The interviews included a lot of talk about the anticipated benefits, like the removal of the need for venipuncture and the reduced wait time for the RNA results and the earlier treatment initiation. And one of the interviewees recognized that there's always people who are really hesitant about blood draws, and so they might find the finger sticks to be particularly appealing. Of course, anticipated challenges. We talked already about the concern about the difficulty obtaining sufficient blood. Someone brought up that there could be some hesitancy to use new technology. And then we also have had concerns about the logistics of waiting for the test results, since these results can take up to an hour to return. And then finally, the interviewees talked a bit about the possibilities for scaling this test, and how we could potentially use the information learned from all of these different pilot studies to help identify who's going to benefit most from the point of care RNA testing. And ultimately, of course, we want to use this to try to address Hep C related disparities. So in terms of our real world experience, we just launched the device only 2 weeks ago. So it's only been 2 weeks in the field. All of this stuff and the preparation that I'm talking about has been about 9 months, actually. So I guess our project has been longer than 2 weeks, but we've only been using it for 2 weeks. Before our first shift, we did a full run through with all of our workflows and procedures, and included a sample test run. And then on site, because we have different sites, the staff does a run through of the new workflow at each shift start, because this really is a big change to our existing workflow. Right now, we anticipated just planning and expecting to have a low volume for the first 2 to 4 weeks, just to make sure that all of our processes were in place, and then to sort of increase our volume once we felt a bit more comfortable with the technology. We've been adjusting the field survey instruments based on feedback. And then right now, we're still working on the automated process of getting the results reported to the Department of Public Health. And so since it's not automated yet, we're relying on manual result reporting. So at the end of each day, manually reporting those results. So in the past 2 weeks, since we just started this, we have performed Hep C testing for 21 clients. We did that, that workflow, that algorithm that I showed you, and 8 people, so 38% were triaged to the Hep C antibody, 13 were triaged to the Hep C RNA. Most of this was people who had reported a prior history of hepatitis C. There were 2 people that didn't have a prior history but had a potential exposure in less than 6 months. Everybody who got triaged to RNA elected to get the finger stick point of care over venipuncture. And among those who did get the RNA, we've been fortunate. We haven't had any indeterminate results yet. 10 were not detected and 3 were detected. So 23% of those in the RNA point of care group. So just quickly, some lessons learned. It's important to learn from others, which is what we're doing right now, which is why I was very happy to be invited to talk with all of you. Really take care in developing the procedures and workflows. It's a lot to sort of think out and think about how you're going to incorporate, you know, the RNA testing, the change in the amount of wait time, the disclosures on the same day. Those all have to be sort of thought through before we use the device. And then I recommend starting small and growing from there. I mean, I want to do lots of testing, but we had to kind of rein in and just keep it a little bit slow in the beginning and work through it. And we have to remember that as our testing volume increases, we're going to have more positive results, and linkage and treatment will increase. And so we really want to make sure that people who are tested and test positive will be able to be adequately linked and started on treatment. We should expect trial and error, as we've already heard, and then ongoing evaluation is so valuable. So I want to thank all the team from the VAN, some of the other studies, the CSF community, and the San Francisco Department of Public Health, and all of you for your participation. Thanks.
Thank you, Jenny. So I'm Katie Burk. I'm from Pacenti Consulting, and I am a former viral hepatitis coordinator in San Francisco. And we're going to have a Q&A now. So feel free to add any other questions you have to the chat. There's already a couple there that I'll go back to. So someone had asked about if there was any issues with using the machine in the mobile outreach vans. And I know Dr. Ohlsen had noted that it wasn't approved for mobile vehicles initially, but then there is a clarification that it could be used in the mobile vehicle as long as the vehicle wasn't moving. So that's helpful guidance. I'm wondering how that's worked practically for you in your space. I know in conversations with folks at Deliver, there was concern about like, where are we going to fit this thing? So it's not just about if it's functional, but also kind of how just sort of spatially that's worked. So wondering if you can say anything else about using the machine in mobile outreach vans.
Yeah, so we also clarified with Cephia, just like Dr. Ohlsen said, to make sure that we could use it on the van, because the van was not, they did the initial trial was not on any mobile unit. We have not had an issue. We take the machine on and off. We don't want to leave it on the machine or on the van, in part just because you know, of security. So we actually have this big, it's right behind me, this Pelican Air like case that we put the machine in, and it's got wheels and roll it on and off, and it has not, it's not been any issues, no problem.
Do you have anything you want to add, Dr. Ohlsen?
Oh, we haven't had any issues.
Okay, great. And then, Dr. Price, I know that your group, or I think some of the folks that you work with, correct me if I'm wrong, but you had been involved with a study prior to implementing this in the field that sort of, you know, kind of tested the technology and invited folks to try the testing as part of the research, supporting the kind of efficacy of the intervention. I'm wondering how that impacted sort of your planning for rollout and implementation, like in real life, and what things you maybe did differently that you wouldn't have if you hadn't done that study and had that experience?
Yeah, that's a great question. I mean, I think the biggest difference is that now the operator, the people that are operating the machine on the van had prior experience with the machine. So, so that part has gone fairly smoothly. The staff was still, you know, wondering if there would be any more difficulties on the van. It's just, it's sort of a different population than had been included in at least our side of the trial. But I think having that familiarity with the machine, with the need for the amount of blood that you need with the finger stick was actually pretty helpful.
And you both spoke a little bit about, there was a question about issues connecting the machine with electronic reporting. And I think we've heard that you both are not doing that yet in your locations. Can you talk a little bit about sort of the vision for what this will look like down the line, the work that it's going to take to get there?
I guess from like a health department perspective, this is a perennial challenge for any point of care anything, and for honestly just getting some of our facilities to have electronic reporting capability for anything. So we really have a mix of facilities that are able to do electronic reporting sort of in general. And we don't want that to be a barrier to people adopting point of care testing or to do same day treatment initiation. And so my colleague Nico, who's on this call, and I think is commented in the chat, has been just really amazing about sort of taking meeting clinics, you know, whatever they're able to do, and taking Excel spreadsheets or fax things or whatever. I think in a perfect world, we would always have electronic reporting, and would love to have simple report up and going. I think that will be our probably our most realistic bridge to having consistent, helpful, perfectly formatted, timely electronic reporting.
Thanks.
Yeah, I don't have much to add other than it was a big barrier for us, but our health department colleagues have been so patient and very helpful at sort of troubleshooting and figuring out solutions, even if they're temporary, while we're still trying to work out the hiccups. And I'm just not a tech savvy person, so it's like I can't even articulate exactly what the problems are, but you know, part of it is just reporting in real time from the device does not have all the information that needs to be reported to the health departments, is sort of my way of understanding it. So there's the you know, results are there, but you don't have any of the patient or client factors that actually you need. So it's sort of extracting that and then sending, but also merging with the other information that we collect in the field and then sending that to the health department in a way that's, you know, secure, electronic, and automated is challenging.
Great. And then there's a question in the chat from Kaylin Mitchell that asks what labs were used for Hep B, Fib4, CBC, CMP, etc. Just the clinic lab, or did you have to use the reference labs?
So most of our public health centers don't have clinicians and don't have labs other than point of care testing. And so recently we've been able to develop contracts for some of our public health centers with, you know, LabCorp or Quest or whoever is the best contractor to serve what can be quite remote communities. One of the clinics we're doing this testing in is not on the road system, for example. And so we priced out the hospitals in town, and it was more expensive than going with a regular sort of national lab. Our public health lab does do Hep B and Hep C, but they don't have like a chemistry analyzer or do routine labs. So we kind of do we do a combination of whatever works best. But it seems that using reference labs for routine clinical labs and then Hep B, Hep C through state public health seems to be a reasonable compromise at the moment.
Yeah, and what we do is so we kind of have these two phases. We've got the screening and then we've got sort of the treatment phase. But when we were doing the screening with the send out RNA, we have an account with Quest, and so we'd send the RNA to Quest. But all of the other labs that we're doing, we just bring back to UCSF and use our UCSF clinical lab. At that, because we have these multiple stages, we get the insurance authorization, so the insurance will cover their testing. We could also send out to Quest, and when there were some lab delays for COVID reasons, you know, earlier in the pandemic, we did actually switch to Quest, but those are all, we send them as, you know, standard of care. and it's covered by insurance. But one thing I guess I would say is when I'm able to access the patient's electronic medical records, I'll often find that a lot of the tests that we sort of want to get done before starting treatment has already been done. And so sometimes I'll go through everything and say, oh, this person doesn't actually need any additional testing. So no labs are needed.
Right. And then there's a question from Nathan in the chat that asks about the quality of training from Cethia during the instrument setup and the training with the expert Hep C test, and that there's been some variability in the quality of training and coaching around the finger stick technique. And then related, folks are asking about getting the machine, setting it up, maintaining it. Can you talk a little bit about those parts of the kind of implementation?
Go ahead, Dr. Price.
Oh, yeah. Well, so in terms of the training from the company, so as I had already mentioned, some of our staff were already very familiar with doing the testing, so they didn't necessarily need more extensive training or coaching. So they were kind of familiar already with the finger sticks. So maybe Dr. Ohlsen can talk about that. But in terms of the machine, like getting the machine and setting it up, it was fairly smooth, I would say. I mean, there are hiccups. So I think that we got the machine, and then the Cepheid folks came to do a demonstration and the startup, and something wasn't working on it, so then we had to like replace the machine. But they've been very responsive.
I guess for us, we originally had both units delivered to the first of the two sites, and so the Cepheid rep came up and demonstrated that, and the public health nurses at that center had good feedback about that training, and they were pretty confident about going forward after that training. We then shipped one of the machines up to a bigger community, which happens to be the one I live and work in. And so I basically kind of took receipt and took it out of the box, and I found it pretty straightforward. I had to call the rep for password help, but otherwise followed the directions of the booklet, and it did what it said it would do on the box. And the real issues were really just kind of about getting a good enough sample and being able to get the blood volume that you need in the right place before it all clots off. And so, I don't know, I probably did 5 or 6 on myself before I got really confident. And I didn't have to run 5 or 6 expensive cartridges in the machine, but I did have to poke myself 5 or 6 times before I got a really good technique that was consistently getting enough with a standard lancet, and then what the clinics ended up doing was going to the supersized lancet to not have some of those issues. So I think the finger stick technique is really important. And when you're training people who haven't done a lot of finger stick techniques or haven't done them on, I guess, outside of sort of a hospital setting, it would be pretty important to spend a lot of time on that. I did train the local health department on it. This was not their first rodeo, and they've done really well with kind of resolving that and figuring out how to make it work, other than the equipment malfunctions that I mentioned.
And related, I mean, we've heard a lot about sort of like the concerns and kind of the trickiness of needing to get a larger quantity of blood for this test as opposed to the rapid antibody test. And so I'm hearing that you've developed some strategies for that, making sure folks are hydrated, that their hands are warm, that you're going into a finger that's not particularly calloused. I'm just wondering about what you're hearing anecdotally from the patient perspective about kind of the acceptability of having this amount of blood needed. And also, I know something that came up in our work on evaluation with Deliver is folks being concerned about having to wait longer for the results of this, and that this is like a busy group of folks. And if you're out on the street in front of their SRO, like they might have stuff to do and they might not want to stick around for the results. And so just wondering what you're seeing. I know it's very early days for you all, Dr. Price, but sort of how the acceptability has been in your small sample so far.
So it's very early for us, and so far it is going well. But we're sort of incorporating questions, asking people about that, so we can get some sort of some data to inform our decisions moving forward. So far, so good. But as you saw, we've only done about 13, I think, of the actual point of care RNA tests.
For our part, this test takes 40 to 60 minutes to run. And so we have not had many takers to stand around and wait for the results. And I think I mentioned that there's been substantial challenges, especially in our larger area of finding people after the test. I was on a call earlier this week or late last week where the Portland area Indian Health Board, which has been doing this for a while, said that they'd moved to a strategy of providing an incentive at the time of testing and another incentive for patients waiting for the test result, which I think is smart, and we'll probably look into doing that.
Yeah, I think I should add, our sort of regular flow before we added this, we have all of these steps also where we collect a lot of information from people and do surveys. And so it turns out that when people were getting the antibody test and then waiting for the results and then getting the venipuncture, people were hanging around for well over an hour to begin with. So we kind of, when we were designing our workflow, just figured, well, let's just do the RNA, the point of care RNA upfront as much as possible. I mean, obviously there's, the consenting and other stuff, but the RNA as much as possible, and then do all of the other stuff that we were doing before. We could just do that with people while they were waiting to kind of keep them occupied. And so I think that might be why it wasn't as much of a transition as we had kind of worried about, at least in the first 2 weeks. And then also we also do provide incentives for results disclosure, so people have a little bit of an incentive to stick around for the results.
Great. And then I know we kind of talked about this, or it was glossed over a little bit before, but Dr. Ohlsen, you were talking about sort of like the hepatitis B testing being sort of a barrier for implementation and that changing with the guidance changing. Can you just talk through a little bit more sort of how that was a barrier, what the implications are for the change guidance, what that's looking like for you all kind of previously and then now?
Sure. So we've been working with the hepatology program with the Alaska Native Tribal Health Consortium, and they had certainly been looking into the issue of the recommendation stating previously that that you need Hep B status before starting Hep C medications because of the risk of activation. And the hepatologists we were working with, didn't think that it was that big of a concern, but we really kind of need national guidelines because we don't have the ability to set guidelines in-house for that type of sort of subspecialty recommendation. And so our approach had been to wait for the hepatitis B result before starting hepatitis C treatment. And we knew that other places were implementing same-day treatment start, but we just could not figure out how to do it with our pretty substantial hepatitis B turnaround times in the state. And I won't tell you what those are, except to say that I hope yours are much shorter. So recognizing that was kind of a barrier, and I think that the guidelines that we are now aware of that talk about counseling a patient on the risk of hepatitis B activation with Hep C treatment, but also that this is relatively rare, especially in a population that's relatively well vaccinated. In Alaska, the Alaska Native population tends to be fairly well vaccinated for hepatitis B, at least those beneficiaries who received care in Alaska through tribal organizations during childhood. But we know that our vaccination rates statewide are not as high as we had hoped, and so the risk is not zero. And so we're working on a little bit more of kind of the describe the epi to inform the risk. But I think that the bottom line is that now that there's national guidelines, it's going to be much easier for us to do some new treatments.
Is there anything you wanted to add about your experiences, Dr. Price?
Yeah, I mean, I think the main thing that I would say with the hepatitis B testing is if you feel that you could you confidently can contact somebody to let them know that the surface antigen is positive if it in that rare case where there is somebody who's living with hepatitis B and is unaware, then even with the long, I won't ask how long the turnaround is, but if it's a couple week delay while they're on the DAAs, the risk of reactivation is thought to be very low on DAAs, even with surface antigen positivity, just for first couple weeks. So the key thing is really just knowing that you're going to be able to contact somebody to let them know of their status after you've already started the DAAs. So there's different ways that you can approach this, and one could be just to, and all of them should include having the conversation, but you could start the DAAs and just say, if you get the call from me, make sure to answer. If you make sure that you have some way of contacting somebody if they don't have a phone, have them check in to get their results or something. Or you could give the DAAs and then say, wait until my my thumbs up to start. And I think it's really up to every group to decide sort of what's best for them and for their clients.
Thank you to both Dr. Ohlsen and Dr. Price for sharing your time and expertise. I think we are at time, so I'm going to hand it back to Zakia and Isabel.
Yeah, thank you all so much. Thank you so much, Katie, Jennifer, and Liz for such a great conversation and discussion today. Thank you everyone in the chat for these really great questions. I don't know, this is a really exciting time to see how we're implementing this new technology. I don't know, 2 weeks is crazy for just being implementing and already speaking about all the work that's been done just to get to the point of only having 2 weeks worth of testing. And it's also amazing to hear about Alaska and being able to implement this in a really rural area as well. So yeah, we would also love in the future to hear more about what other jurisdictions are doing for testing. And yeah, I don't know, just thank you all so much for such a great session today. We really appreciate it. And yeah, we'll definitely keep talking about this and seeing how we're able to spread this around and really try to improve linkage to care for Hep C. So thank you all so much. Have a great afternoon. And yeah, we'll be posting that information soon.